Satya will arrange it in another just a couple of minutes.
Yeah, sure, sir. Sure, sir. Thank you.
Get ready, I'm not supposed to guide you. Okay, I'm not supposed to guide you. Get me the under twist wire now. Take out this terminal wire. And under twist wire. Open the 24 French long sheet ready. I'm not supposed to guide wire comes out. Take it out. This under twist, keep it in the center. Keep it in the center. This comes out. You're holding. This wire should not come out. This wire should be at that level of depth. And when you are pressing here, this wire should not bend here. It should not. The wire should not make it. Like noise and Qureshi.
Hello.
Now you have completed the vascular access. I show the fluoroscopy.
So you are started to loading, right? I found that you've already taken out the delivery system.
I am now putting in the 24 French sheet and then I will start preparing the valve.
Okay.
This is a 24 French tooth long sheet. The plan was to deploy from the right pulmonary artery, so I'm taking it into the right. taking the turn. It's not taking the turn. Hold it here. Grip it. Show the wire. Come here. Hold it here. Joyce, the sheath is not taking the turn in the RVOT.
Okay.
So I'm stopping it here.
Okay.
Now going to
Loading.
to see whether the venous delivery system will make that curve.
Okay.
Get the arterial pressure in the arterial gains. I don't want the PA pressure. Right hand is clear. Whole picture. Completely bad. Yeah. We are allowing that. Hold it at a distance. Not do a tension on the valve. Delivery system is out for you. Here. It's like this. Yeah, check the wire position there. Now shall we make one angiogram for our landing? Come to RAO 30, RAO 40. Cranial about 40. Cranial mode. Table little Ready? Ready? Go to one yellow cranial also on this one antenna. This is 40-40. Yellow 40-40. Then Worakan to take to the Worakan from my phone. But see the angiogram. Cranial bone. Come towards me. Come towards me. Ready? Fine. Now get back to APU. Just one more same. Worakan, are you online? Worakan? He said that he would send it. So send a message to him. Well, get the Joyce, I am now beginning the loading of the valve. Can you hear me?
Yes, yes, I am. Yeah, I found you already flushing the delivery system.
Joyce, I'm putting the protector.
Hi, Shiva.
Yes.
Are you online?
Yes, sir. Dr. Worakan is now online, sir.
Go to Worakan, the angiogram.
Shiva, I can't hear you well, but yes, if Stavya, if you can repeat what Dr. Sivakumar mentioned, that would be great.
Worakan, you have a look at the two angiograms. Show
Yeah,
the
I can
two
hear you.
angiograms.
I can hear you now.
Number is correct. 36, 25, 25. 310. 619. Timer on. Timer on. Show the angiograms to Worakan.
Yeah, I can see angio now.
Worakan, the problem was my 24 French sheet is not able to manipulate beyond this point.
Hmm.
The 24 French is not able to go beyond this point.
Yeah. Because it's
So-
too short or because of what? Shiva, is it because the sheet is shorter than the length of the patient or because of what?
Repeat your question again.
Yeah, the reason the sheet cannot get beyond that point is because the anatomy or because of the too short of the sheet.
No. Sheath, I have another 10 centimeter outside. I am not able to push further.
Okay, so it
The
means that
24
because of
sheath
the
is
anatomy.
quite rigid,
Yeah.
so it is not able to manipulate further.
Okay.
So I am left with the option of only putting the sheath up to this point.
Hmm.
In fact, I doubt after I get the venous valve, the nose cone beyond the tip of the sheath,
Hmm.
I think I may have to withdraw the sheath in order to manipulate it further, because I think it will be difficult for me to manipulate with this rigid sheath.
Yeah. I think so.
The sheath, even the dilator made just a very minimal turn towards the RPA.
Yeah.
Again, the left pulmonary artery was at a quite sharp turn. In fact, I was originally positioned the pigtail catheter in the left pulmonary artery.
Hmm.
But when I was trying to do an angiogram, it slipped back into the main. So I understood that the left is not going to be a stable position for the pigtail catheter. So I have left it in the same position. Show the RAO also. I am thinking about this RAO as the working view because this separates out the right and the left.
Yeah.
So to have the distal flare, the uncovered flare totally into the right pulmonary artery, if possible,
Mm-hmm.
and then start the release.
Yeah, Shiva, do you have the LAO cranial view?
LAO cranial, show the next one. This is the LAO cranial.
Ah, I see. Okay. All right. And do you have lateral?
See, the lateral was completely confusing. Lateral,
Okay.
even in the diagnostic, the angle of the right ventricular outflow tract from the annulus towards the distal bifurcation is like coursing from left to right. So the lateral, irrespective of however much cranial and caudal that I could give, I was not able to get a good position. Can you do one thing? Can you show to Dr. Worakan with this phone the previous lateral cranial and all? Worakan, I will, while I'm rinsing the valve, one of my colleagues will show you the previous lateral.
Yeah, would be great. Thank you. And for the camera, please, if you can, have some stabilizing kind of stick or whatsoever that, not moving so much. Otherwise, I'm get confused.
Sure. I will try. Actually, the camera should not move much, so that the person who is seeing from the other end will not have a vertigo. So, and from the other camera. Inform Satya to transfer to other camera.
Would be great. But in the meantime, I didn't see the lateral view, but I believe what you said. So so
Worakan,
far,
now the lateral view. I have some time because I am now only with the second bowl.
okay.
We'll get the lateral view now shortly. Put the other camera, Satya.
Yes, sir. It's already on.
Yeah, but I
show the
see
picture on the angio.
the RAO view, I think that one. Yeah, this one is RAO view. And so the camera, okay, so that one is lateral. Yeah. So to me, Shiva, the working view, if you have just one view, I will mainly prefer, if I were you, I would prefer the RAO cranial view. So that's to check the landing zone, especially for the distal landing zone. And I may, from time to time, move the camera to areocranial in case I
Sure.
need further confirmation. Otherwise, I will mainly go for the areocranial view. What do you think about that?
Yeah, that's what I'm also thinking. Shift between RAO cranial, initial part of deployment in the RAO, and
Yeah.
then the moment I have 50% of the valve out, then shift to repeatedly to LAO cranial and confirm that we are okay.
Yeah.
The first concern is, this is what you are seeing is the lateral view, Worakan.
Yeah.
Inform what is the lateral, what is the cranial angulation and all in that. Ask them not to move, like keep the camera stable when they are showing.
Now it's much better. Thank you. And just remind me again the waist diameter,
The
length of the waist.
The maximum waist was 30, 31.
31. And we prefer, and you load 36 by 25, am I correct?
Yes.
Okay, all right.
In fact, that is the only valve that I have, Worakan. There is no standby valve.
Right. Hmm. So Joyce, are you still online?
Yeah.
So any comments from your side?
I'm agree with your comments.
Okay. Allow me to have lunch. I'm having lunch.
Oh, really?
Yeah.
Oh, right now it's around 1 p.m. Huh?
Yeah.
Just finished the clinic.
No. I had breakfast late, so I had lunch a bit late.
It's quite late. Yeah. Hi, Dr. Sivakumar. You are the third bowl. You are doing the third bowls, right?
This is the third bowl. Number 3.
Okay. Yeah. Okay.
Worakan, 5 is enough, or do you want one more rinse or 1 or 2 more rinses also?
Okay.
No, is 5 bowls enough? 5 into 3, 15 minutes, is it enough? Or do you want me to do one more?
Enough, Shiva. It should be enough. 5 bowls and about 1 minute each of them should be enough. Take your time, don't worry.
Fourth bowl, Joyce.
Yep.
Worakan. Worakan.
Yes, Shiva.
In case, in the case, in one of the patients, when you did the right pulmonary artery of deployment through the jugular approach,
Yep.
did you use an amplat superstiff guide wire or a Lundquist wire?
Done the quiz.
So the Lundquist takes that sharp, full 360-degree curve.
Yeah. I'm afraid that if I use that day the implant super stiff, it won't go through because it's quite very acute angle, and the wire, if it's not stiff enough, it may not be able to track the stiff system. So for this patient, I mean your patient, I also think that if he needs a right IJ, I may prefer the Lundquist.
Okay. I have put the respirator on the left side and cleared the entire right shoulder corner of the patient free.
That's
but
lovely.
I wish I don't need to resort to that approach because I have not done a valve from that angle.
Yeah, we'll see if the conventional way works, and then we don't need to do it in different ways.
This is the fifth bowl, Joyce.
Yeah.
I'm having lunch, Shiva. Sorry.
It's too early for lunch and the adrenaline is so high that glucose levels will be at sufficient to last me through the procedure.
So it's 11:30, right? And
yeah,
in
11:30.
place. Okay.
11:45.
Oh, right. Oh, yes. Yeah, 1.5 hours. So after this, you can be the crimper, huh? The loader for the Venus MedTech. Joyce, you need to ask the Sivakumar to be
Yeah.
involved in this
Yeah.
for Venus
He Dr. Sivakumar, his hands, the skill is very good.
I'm wondering myself whether my eyes is good enough to do this.
Oh.
My hand is still fine, but my eyes, I'm not quite sure. But yes, I think I need to practice just like Dr. Shiva Kumar did too. Shiva, in my hospital, I asked my nurse to help me on loading the valve, and they
Yes.
did very, very great job. And lucky me that I don't have to.
Yeah, all my nurses are far younger. They have good vision. I am the only blind in this group.
No, you're still young.
flush all the lines, Ashish. Zishan is holding, so flush all the lines. Arterial, venous, pigtail, neckline. We have a short 24-pen sheet. So in case if I have to go through jugular, then I will need that short 24 pen. We have a short 26-pen sheet. Gore is there? A gore dry seal, no? So that's a short one, no? 30 centimeters. So in case if we through the jugular, we will first put the 26 gore dry seal, short gore dry seal, and then take the valve inside. Okay, Joyce, 5 into
Yes.
5 cycles over. Now I'm putting in saline, ice.
I found the loading basin. The saline water is not enough, right? I found the liquid is not enough. Maybe 500 more.
Okay, 500 more. 500 more saline.
One more. Yeah. Because I found that the valve is not totally inside.
Yeah. Okay.
Should be totally inside.
Just plain saline. Yeah. So now I am taking the first big.
Yeah. Okay. But without the fully liquid inside, maybe it's hard to the crimping.
Tell it again.
Yes. Right now I think enough. The water is already enough. Okay.
Second.
Yes. Okay.
Third.
Yep. Okay.
Small one.
Yes. You can rotate and crimping. Okay. Dr. Sivakumar, I suggest you can take it out one eye. The back one. Yeah.
That's it. No, little here. Little counterclockwise.
Two years you can bend inside. Yep, good.
No, you have lost. You again get it. Okay. Start rotating. Rotate, 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 rotate. Wait. Just go out. Yeah, out. Rotate. In. Enough. Little bit more in. Enough. Little.
Sir, Dr. Shak has joined.
Shak, welcome, Shak.
Good
Hello.
morning, Siva.
Okay.
The voice.
Joyce, you see, Joyce, 1
Afternoon.
centimeter I have loaded.
Yeah.
Okay,
Yes,
and you can crimping the crimper and touching the loader, and you can ask assistant doctor to rotate the delivery system.
Yeah, in. Enough. So,
Okay.
Joyce, shall I
Take back,
open up?
pull back the loader and to check. Yes, and you can rotate the whole system. Yeah, to check whether all the stents inside or not. If yes, and then you can move forward
Okay.
until the cover the half of the body. Yeah, and take it out the crimper. You can rotate the whole system to check whether is there any infolding or not. And rotating and to check whether infolding or any kink. Yeah, if not, and you can move forward.
Rotating.
Yeah, good.
Some minor variations are there here.
It's okay because the other one is the biggest size, so it's okay.
Okay. So now, should I put again the crimper?
Yes.
Rotate. It looks
2 years
okay.
is inside. Yeah. It looks okay, and 2 years is inside, right? Still hang on the hooks, right? 2 years.
Hooks, show the hooks. Shall I open
Okay.
up? Ah, 2 eyes are open.
Okay. Yeah. We can move forward in the water.
So shall
Yeah,
I put
in the water.
I'll push the
Use your left hand to pull back the loader until the touch the meet the yellow radio packaging.
no, shall I first cover it totally?
Yeah. Use your left hand to pull back the loader. Use your left hand, right hand hold the delivery system. Right hand hold the delivery system. Yes. Pull back in the water. Yeah. In the water more easy. Yeah. Until the yellow radio packaging.
Yeah, yellow ring is here now.
Yeah. So should be more close to the yellow radio packaging.
Okay.
More. You can move. Pull back the loader more.
Loader more towards the
Yeah. Around the radio packaging. Yeah. Around the. Yes. Okay. Then you can insert the supporting tube. Okay.
in
In the water. Yes.
in
In the water.
yeah in okay stop.
You can push the loader loading to more left side. Otherwise, you cannot touch the empty part. Yeah. Yes. You have to hold the metal part, not the empty the capsule. Yes. Move forward. In the water.
In 1 second.
Dr. Raya should be more quickly.
Wait. Ready. In 1 second. In stop. Okay, ready.
Not the empty part.
Stop. Stop.
Dr. Raga, do you have any resistance or no? No, right?
What is that?
The assistant doctors, he did not feel any resistance, right? When he rotating the micronaut.
Any resistance? No resistance. No resistance.
Okay. Oh, so that's perfect. You can when Dr. Sivakumar pushing, you can fastly to rotate the micronaut.
Okay.
Okay.
Rotate.
Yeah, rotate and check 2 ears and the stand.
Two ears are okay. Just see once again.
Okay.
Yes, sir. This is ear is on. Ear is controlled. Yes, sir. Yes, sir.
Rotate.
Yes, sir.
Okay.
So now little bit more. In. Okay. Flush that.
Flushing.
You're flushing the proximal.
Proximal.
Okay. Shak, you are online now, Shak?
I am and I'm awake.
Okay. Shak, we will show you the two angiograms. Can you show the angiogram?
Okay.
So contrary to the plan, I was not able to get my 24 French sheet beyond the proximal RVOT. It was very rigid. Now go to, no, don't show me. Go to the fluoroscopy. Go to the fluoroscopy. Rohit, this is done here. Go to the fluoroscopy.
Are you on the date?
So that's the 24 French cook sheath, yeah? Yeah.
Unmute. Is the word.
And which wire is that? Lunderquist or which?
Shiva, can you?
Shiva, which wire is that? Okay. It's curled up, isn't it?
80%. Right now.
Okay.
Shiva, if you can update the fluoroscopy now to see where's the end of the wire. That concern on the positioning of the wire, whether it's okay or not.
Okay, that looks better. Yeah, that looks a better
This is the
position.
wire position now.
Yeah.
It's like Dr. Shak. Satya, pin the fluoroscopy as the big screen.
Yeah.
So that's already pinned.
Okay, that's a good wire position, yes. So, Shiva, presumably the 24 French sheath is now currently still in the RVOT.
Yes, 24. Now show the AP, the tip of the sheet. Shak, this is where we are currently, the tip of the sheet. I am not able to manipulate that bend with even the dilator. I made a curve in the dilator, but still I was not able to make a bend.
Okay.
I think that's because of the acute angulation between RVOT and MPA. So
Yeah.
the sheet can't get through.
And show a lateral projection.
Shak, I was just telling Worakan about the problems of lateral. Lateral completely overlaps, Shak. The lateral does not show anything.
Okay.
The proximal RVOT is lateral and the distal RVOT is medial. And in lateral, there is a complete foreshortening. We are not able to get any meaningful information.
Okay.
The only two working views are this RAO cranial, which is RAO 40 cranial 40, where the LCA moves superiorly. And the second view is LAO cranial, where the separates them.
Okay. Yeah.
So now I am now taking the show the wire tip. Okay, come back. No need to pull the wire out. Now, Shaka, I have a doubt whether if I withdraw the cook sheet, it will be easier for me to manipulate the RVOT because the cook sheet is rigid and it is facing towards the left.
Yeah, so I agree with you. That's exactly what I was thinking, that you'd have, in order to let your delivery system go around, you'd have to pull the sheath back, yes.
So I'm going to do it as I am pushing my.
Correct. There you go. Perfect. You see how easy that was?
That's lovely, Shiva.
Now come to RAO cranial.
Very good.
That RAO cranial, show the angiogram first. Set 15 ml at 15 rate, many injections. Load a full injector now, full syringe now. That give you 1 minute. The pigtail has got dragged inside. Load the full injector. Show the RAO angiogram once again. RAO. So in the RAO angiogram, the left pulmonary artery was near the jugular sheath and the endotracheal tube. To the left of the jugular sheath and left of the endotracheal tube. We still have to go deeper. Full syringe.
And if you can pull the pigtail back to near the bifurcation and then do another angio there.
Now, 15 at 15. Ready? I'm reasonably deeper shack. I will open the distal flare and then slowly start coming back. Or do you want a better picture?
Hold on, I'm just trying to see how much distally you are.
Shack, actually, the left pulmonary artery is on the shaft of the valve now. The proximal shaft of the valve. The proximal is in the main pulmonary artery. The distal half of the valve is in the right pulmonary artery now.
Yeah, so I think you need to pull back the whole system at the moment until where the current pigtail is. That's where you need to have a little bit of.
Weight going up is the. I'll make a better quality angiogram.
All right.
Right, has already.
Share a bit my idea. I think if we can open the flare here, and just to keep the distal marker not beyond the bifurcation. My thought would be because the landing zone is so short. So if you can flare a bit here and then try to pull back later. I'm not sure whether it helps or not.
Yeah.
So we will open up the distal flare and we will. We'll
So
try
that so that actually gives a better view now, doesn't it? It shows you where the origin of the LPA is. So yeah, you can open the distal flare a bit here.
Okay. Yeah.
Dr. Sivakumar, as you know, when you release some a little bit, and you should be waiting because the strength is inside. We have to leave out all the strength for the delivery system.
I didn't understand, Joyce. Repeat it again.
And yeah, normally when we rotate the micro knob, maybe you rotate it many times, but still the delivery system is not move forward. And then at the moment you can stop and let the delivery system only to release the strength inside. And then later it will be calm down.
So there's a delay, Shiva, between rotating and the the covering pulling back because of torque. So if you go slowly.
Okay. Sister, hold these two together. These two together. Screw, wire and that together. Okay. Now. Yeah. Open. Both these you have to hold it together. The wire should not come out. Half of the distal flare is exposed now, Shaq.
Yeah.
The valve is looking very constrained. Now the entire distal flare is open. It's looking constrained. Stop there.
Yeah. It will take a while before it opens, so you have to just allow it to expand.
Yeah. Good. Yeah. Now it looks like it is a little deeper now. So I am thinking about advancing the Lander twist and little bit getting it out the delivery system. Or should I do Instagram? Give 20 at 50, 20 20 at 50. Ready? Freeze it. Okay. Shaq and Worakan, it looks like the proximal end of my valve is almost on the middle of LPA. So shall I come back a little bit?
Yeah,
I think yeah, I agree. Yeah.
So Shiva, another thing, if I could say, I think the cook sheet is a stiff one, and that makes the system bend quite a lot. I'm not sure whether we can pull back the cook sheet also a bit, just to ease up the tension around the system while you're pulling the delivery system back.
Okay.
Yeah.
I have pulled back the system little bit towards little bit. Yeah, stay there. So now am in a better position now. 20 at 10, 20 at 15. Shall I release half of the valve and do the further manipulation?
I think so, because I think as long as if you keep an eye on your pigtail, it's in a good position, showing you where the origin of the LPA is.
Yeah. Okay. Keep
They agree.
about a recoil. Okay. A little bit more. Release half of the valve.
I would stop there, I think.
Okay. Now 50% of the valve is released, and now my valve is across the left pulmonary artery. Shall I give a little bit of push on the wire?
And pull a little on the valve because you need to slowly come back. Yes.
I hold here. And so again, 20 at 15.
Yeah. So Worakan, what do you think? Because I think I would pull back a bit more.
Yeah, I think so, sir. But be gentle and quite slow. Yeah, at this moment, just push the wire. And just,
Now, see, shall I release a little bit more and then pull back?
No, I think not. I think this is all right. It's constrained, so I think you just need to push the wire and gently pull on the valve in order to let it come back at the bifurcation. And then be ready to push it forwards when it jumps. It's almost there. Okay.
Yeah, I'll make one angiogram here.
Yeah, check angio. Okay, so it's still a little in the RPA. But now push forwards, push forwards.
Okay, now shall I start releasing?
yeah, please.
Yeah.
Keep pushing and releasing.
Keep a forward push.
Yeah.
And be aware of the pigtail catheter as well.
Yeah. Also, now is the time to pull the pigtail back.
Yeah, I'll do that. I'll make one angiogram and then do it.
Yeah.
Do an angiogram now.
Yeah, we have to open here.
Release a little bit more.
So if you pull the pigtail back and then release the covering on up to the valve markers, the proximal markers, before making any other decisions, I think, and keep a forward push.
Yeah.
And is this single plane lab or biplane?
Single plane, Jack.
Go to LMO cranial.
Yeah, I was just trying to work out what's happening with the distal
Stop there.
flare.
Now, go to LMO cranial. Just getting the injector once. Table a little superiorly. Don't expose the tube. Okay.
Keep a forward push.
Yeah. Yeah. Get it, Ashish. Come. Get one injection and then you can keep loading. This got the air bubble. This got the air bubble. Give 25 at 15. At 15.
Okay, I think that's looking good position. I would do another one, same position of the pigtail, but in the original RAO cranial projection.
Cranial. 40, 40. Same. Ready?
Worakan, what do you think? I think that's looking very good.
I think that looks very nice. Again, if I were Shiva, I will just keep forward push while releasing the device, the valve, at this
Yeah.
position.
Yeah, just replay that, Anja.
Just stop there. Okay, replay the previous angiogram.
Okay, so you can see where the original valve is.
Shall I release? Because I doubt whether it will suddenly fall back.
Yeah, well, that's why I was saying that if you come back to just about 5 or 10 millimeters, 5 millimeters before fully deploying, and check again. But come back, yes.
Approximately.
By that I mean release, not pull the valve back. No.
Connect it.
And again, as you uncover, keep a forward push because the valve looks in a good position. And when you're releasing or uncovering, pull the pigtail back a bit more.
Yeah, Shiva, release here.
Yeah, don't pull any more, just uncover.
Wait, no, it's okay.
And picture back, Shiva. Thank you, sir.
That's it, good. Yeah, so just uncover up to about 5 millimeters and then allow that's it. I would stop there and also stop pushing anymore.
Not pushing.
Yeah.
Angio.
And angio there, yes.
Like if it just falls down, then it will be fine, I think. I have hardly 1 millimeter now. I'll release it.
Oh, yeah, so don't push anymore. You can just pull a little at the final release. Just pull a little, a gentle pull. Because now you've got leeway. Yeah, so you can release it, but without pushing anymore. Keep a little pull, if anything.
Okay.
Now make sure both the ears come out.
Right? Okay. Now,
That's it. Perfect.
That's lovely, Shiva.
let's see whether the ears are. Wait there, wait there, wait there. Wait there.
I think that's looking very good. If you check in eleocranial as well.
Hello? I'm not seeing the ears. Are you able to see the ear? One ear is bigger.
Well, the only other way is to, oh, well, they must be out because your covering is way back.
One is definitely released. The proximal one.
If you do the angiogram, you might see better. If not, if any doubt, rotate your delivery system because that will just unping the ears. But I'll do an angio first here.
Angio in this RV.
RV angio in that eleocranial.
Put it on full fluoroscopy, like not like medium dose and all. Okay, 25, 15. Ready? Little bit table up. Yeah. Ready?
And then replay that.
Shaq, one of the ears has come out clearly. The second ear, I'm not able to see it. I will change the position and see.
Okay, have a look on the straight AP and different projections.
Wait,
We can't tell because the quality. Yeah, that's a better.
I think both of
Yeah.
them are already, huh?
Yeah, that's a better picture. So yeah.
Shiva, if you can do me a favor now, keep the picture just close to the RVOT and do injection at the cranial. Just one more injection. Because at the apex is very difficult to have a look because it's diluted contrast.
shall I put in the pigtail into the pulmonary artery and inject?
Yeah, that's all right. Yes.
Then can you go to APV?
Actually, Shiva, what I would do before doing the angiogram, because what will be happening is your delivery system is probably restricting the valve motion. So what I would do is do an angiogram just for the bifurcation, but for the valve competence, you'll have to repeat that once the carrot and the delivery system is pulled back.
Shall I take out the nose cone now?
That's what I would do now because the two ears are released, yes. So if anything, pull on the wire a little bit as well as you pull. Yeah, that's it. Now you can push the wire a bit.
Come to
Okay,
LP.
good. So that's out of the way, and now you can do a MPA distal angiogram. That's good. The carrot is now inside the sheath anyway, so that's fine.
Go to the top. Okay. Come to RAO, RAO 4040. Yeah, that's good. That's good. Connected. Take it up. Give 30 ml at 15 rate. 30 at 1.5. Ready?
Look at that, yeah?
Just come down more than what
No. So your valve markers are where you can just about work out where the valve would have been. And the leaflets are working well. And your branch pulmonary arteries are patent. So I think if you do the other, look at the origin of the left pulmonary artery.
completely distal to the distal flash right now.
Yeah, so I think that's all right. And then if you do an LAO cranial, and then I think a final RV angio.
The question is actually the entire pyramid, the distal flare has thrived on the apex of the pyramid rather than going beyond the apex of the pyramid.
Yeah, but if you look at the RPA origin, I think your flare is pretty much against the origin, isn't it? If you on that still image, if you go frame by frame backwards and forwards, yeah.
This was
Yeah.
the king of the LPA.
Yeah. And so your flare is pretty much, part of the flare is against the RPA and part of the flare is against the LPA. So I don't think you could have the flare more distal. I think that's as good a position or ideal position as you can get. I would do an LAO-cranial angio as well.
LAO cranial.
With JAXA, and I think that's the best position that we could get for this.
Yeah, do you agree, Worakan?
Totally agree, sir.
Thirty at 15 ready.
And I think this will show you that distal flare is opposed, if anything, slightly, the left pulmonary artery side of it is curved in because it can't go any further. So I think that's as good a position as you can get. And you've got a perfect result.
Is there be a chance optimal milking now?
I can't see that because the valve is, what diameter was this valve?
36.
36, and it looks opposed to, just do an RV angio in the other projection.
After I take out the lateral square.
No, you can do it now if you want. Yeah.
Okay. So shall I pull back the pigtail and then make an angio?
Yeah.
In the LAO view or the
RAO, I think, yes.
show the previous. There was one RV angiogram that we did. Previous. Like that. No, show that. There was one angiogram that we did previous.
Yeah, that had the delivery system in place. So now there's only a wire.
I'll get one picture. But this is before the release. I'll get now. Come to the RAO.
Shiva, I think Shaq would like to have a look whether any seal of the valve to the dilated RVOT or not.
Yeah, correct.
If we can do angio just here, just to confirm what Shaq thought, I think that would be great.
30.
So if you look at that carefully, you see that the proximal flare is pretty much opposed to the walls of both the inner curvature as well as pretty much outer curvature. And then the midsection is opposed to the main pulmonary artery there. And so I don't think the valve will move proximally at all. And it definitely can't move distally because it's right up in the bifurcation. So as far as I can see, this is about as perfect a position as you can get. Worakan, what do you think?
Congratulations, Shiva. I think that's a very beautiful position, as Shaq said. So I think we don't have to worry on migration. And I think everything looks very perfect to me.
Congratulations.
Yeah, congratulations, Shiva. You did that all by yourself.
Big hand.
Yeah.
Yeah.
Thank you so
Okay.
much, Shaq and Dr. Worakan.
That's all right. Shiva, are you happy or have we gone quiet? Shiva?
Are you still okay?
He's thinking.
Okay.
Yeah, I think he's thinking.
Well, he
Hey,
sees.
Shiva, can you hear us?
Shaq, I couldn't hear both of you.
Oh.
We were saying that firstly, it's did you hear about our comments about the proximal flare and midsection?
Sir, you can talk now, sir. You can talk.
Shaq, please repeat, Shaq.
Well, so what I was saying earlier was, can you hear me now? Can you hear me now? Yeah.
Yeah.
Okay. So what I was saying was on that angiogram, the proximal flare looks perfectly opposed to the inner and outer curvature of the muscle. The midsection is completely opposed to the main pulmonary artery, and the distal flare is right at the bifurcation. So that is as perfect a position as you can get.
Okay.
So I think we should offer you congratulations. You can now work on removing the guide wire, and well done. And everybody's offering.
I will do that now.
Okay.
I'm removing the delivery system from the. Give me one second.
If you've got any possibility of measuring pulmonary artery pressures, I didn't see them before, but if you can,
Hold it lightly.
over the wire.
Show the fluid. Holding. Mr. One fluoro. Okay, thick.
Yeah, so once your delivery system is out, if you put a multi-purpose or something just for pressures simultaneous through the pigtail RVE and through the other one, MPA. Yes, Shiva?
Yes, I am now. I have taken out the delivery system. I am now trying to get a catheter across the outflow tract and take.
Yes, and then take the wire
Follow the
out.
wire.
好上你
And then if you measure pressure just near the
Come to the
distal
wire
flare,
stick. Okay. Get me a normal thermo wire. Come to AP view. Show the tip of the catheter. Okay. Okay, now
Okay.
both the RV and PA. Brush both the lines.
I don't know what the pressure was in the PA before the valve, but I'm assuming it was very low diastolic.
It was yeah, it was very low, Shaq. 1 and 2 and all.
Okay, and so now
That
if you
was
show,
quite a bad pulmonary regurgitation. This time I did not repeat too many angiograms. Cut off that. Okay, now show both the pressures.
all right, take a good printout of that, because once the ectopics have gone, that looks like a really good pressure traces. Look at the diastolic there with the dicrotic notch.
Yeah, the pressure traces look good, Shaq.
Yeah, yeah, perfect. So everything looks perfect. So Shiva, from
Yes.
all of us, congratulations to not just you, but the rest of your team, the ones who've been helping you, because they've all been very good.
Yeah, Dr. Dr. Zishan here is the person who was managing the groin, and Pramod was managing the release part. We had we spent a lot of days in this last about 7 days in one learning the tricks of loading from joys, as well as rehearsing many steps again and again. And I thank both of you sincerely, both you and Worakan, for actually I was telling Worakan a short while before you logged in that my adrenaline is running so high. You partially reduced my sympathetic nerve activity by supporting from the other end.
That's all right. You should check your adrenaline levels. That's what I was trying to reduce.
Thanks for asking me and involving me, for this very challenging case. Congratulations to all your teams, and that's another step of the learning and how we can work together, like you just showed all of us here. So again, thanks and congratulations. And also
Yeah, congratulations.
very early in the morning for you, but eventually, you can come to support all of us here. So that's very, very fascinating. Thank you, Shaq.
Yeah,
That's all right.
Yeah.
Shaq, by the way, you will be happy to hear that yesterday we had 2 sinus venosus ASDs quite challenging, one with a long covered CP and one with our overlapping andra stents. Again, went on reasonably well, but I'm just happy to share with you because
Excellent.
Thank you.
Excellent. Yeah.
Thank you.
So,
Thank you.
So now, Shiva,
Yes.
now I can go back to bed, yes?
Thanks a lot. I think try to catch up your sleep again.
Should we
All
take
right.
some breakfast?
Yes. Yeah. No, it's fasting time.
Oh yeah.
Yeah.
Oh,
Yeah.
You
All
take
right. Well done. Take care. Yeah.
Thank you. Thank you very much.
Thank
yeah.
you.
Thank
Am
you
I
so
allowed
much.
to go now,
Yeah, Shaq and
Shiva?
Dr. Worakan and Dr. Sivakumar.
Shiva?
Hi, Dr. Sivakumar.
Thank you, Joyce. Thank you for all the support.
All right. Bye-bye.
Thank you.
Yeah, bye-bye. Take care. Yeah, congratulations again. Bye-bye.
Bye.
Sir, congratulations. Can I stop the webinar, sir?
Yes, just 1 second.
Yeah, sure. I'll continue, sir. I'll continue.
After that, you can stop.
Yeah.
LCA catheter. LCA catheter. Show the highlighted question. Yellow card. Yeah, make it little bit more. Like make it circle. Correct.
Shiva,
Yes.
Shak, I was just about to leave, but can you send me a copy of a CD of this?
Sure. Check. Are you still watching us?
I was.
Just see the coronary.
Yeah,
Coronary
yeah,
looks okay.
it looks good.
This is the on-first view of the valve.
Yeah, perfect. Looks nice and round.
The valve is very beautiful. Very beautiful valve.
Yeah. And okay, so if you send a CD to me, yeah?
Yes. I will send you a CD by a courier.
All right, brilliant. Thank you very much.
Or
And
I can send it to you by email as a zip file also, if it is okay for you.
That-
Whatever.
the zip file, I don't know, that always causes problems in downloading.
Okay. I'll get you a courier.
Yeah. And then if you just, whoever's assisting, make sure they don't push the cook sheet upwards,
Yes.
because that can be quite sharp. All right. Okay. So enjoy the rest of the day. Yeah.
Thank you. Thanks a lot, sir.
All right. Bye-bye.
Okay, take care. Bye-bye.
Future. Show the light button. Sister, scissor and push it. Put on the light. What was this? Needle? Was it 0 or 1? Prepare in reverse. 50. 50 protamine. Can you take that out? Hello. Hello. Hello.
Sir, the meeting can be stopped.
Hello.
Hello.
Chat, you can put one chat.